we like to get started. My name is Atmas Klee, and I'm a gastroenterologist working in the hospital here. And my background is also in neurogastroenterology and motility. And today we're going to discuss gastrointestinal transport and especially the motility. And this graph is, the first slide I show you is rather complex. And in fact it represents all the transport and digestive processes that are currently going on in the GI tract. And we're going to highlight just the transport and the motility function. But this is a very relevant function. And we're going to discuss some general principles of motility, and then later on I'm going to review the esophagus, the stomach, the small bowel, the large bowel, let's say the general principles of motility, and also some aspects of what can go wrong with motility and to what symptoms in the practice that will lead. Do you have any idea about the magnitude of transport times in the gut? Let's say in the esophagus, if you eat, how much time will it take it of the food bolus to get transported through the esophagus? Yes, it's in the order of seconds. And then the stomach. How long will the meal remain in the stomach? Yes, hours, a couple of hours. And it also depends on the nutritional quality of the meal, how the amount of calories and the amount of nutrients, but usually up to 3 to 4 hours. And then the small intestine. I think that's very relevant because in the small intestine you get digested, you get your food digested and absorbed. And how much time will the food remain in the small intestine? It's also a couple of hours. And then the large intestine. No, it's even more than hours. It can be 1 to 2 days. Yeah. So going from proximal to distal, the transit time increases. And in the large intestine, it's especially relevant because you have to, let's say, absorb a lot of water and salts. And to get the food bolus, or what remains, let's say the luminal content, more dense. Something about the anatomy of the gastrointestinal wall. And going from the lumen to outside, what is the first structure you encounter? Outside. From inside to outside. Yes, mucus. And then after the mucus, you have a mucus layer, which is very relevant. Yeah. And then? No, not immediately the muscular layer. You have. Yes, this is the mucosa. Yeah. And beneath the mucosa, you have the. Yes. And then you have a muscular layer. And in fact, the muscular layer contains 2 types of layers. It's circular and it's longitudinal. And first you get from inside to outside the circular layer and then the longitudinal layer. And in between you have an intense network of neurons and you have a myenteric plexus there. So this is what we already discussed, the anatomy of the bowel. And this is again more like a real life picture where you have the, and this is from what part of the bowel you would expect this picture to be taken? From the, because what do you have here? The villi? Yes, and that's usually present in the small bowel where you absorb nutrients, you digest and absorb nutrients. So you have a large plication, many folds of the surface, so you have a large surface to digest and absorb, and you have the submucosa, the circular, the longitudinal muscle layer, and in between the myenteric plexus, and here around at the outer side you have the serosa. So gastrointestinal motility, in the gut you have usually smooth muscles, and these have long and strong contractions, and the smooth muscles also exhibit a basal tone, and they generate a certain tension. And you have locations within the gut where you have sphincters. And the principle of a sphincter is that you have a high resting tone, so that the sphincter is closed. And by that you cannot have transport from the esophagus to the stomach, because the lower esophageal sphincter usually is closed. It only opens when you eat, when you have peristalsis in the esophagus, then there is a reflex, and then the sphincter will open. So there is a high basal tone, and this tone is influenced by neurotransmitters. And what is an important neurotransmitter in the gut? SES? Yes, ACH, acetylcholine, but another very... CCK is more of a gut peptide, it's more a hormone. Serotonin. Serotonin is an important neurotransmitter. And you have a lot of serotonergic neurons in the central nervous system, but also a lot in the enteric nervous system. Drugs are also relevant. Drugs may influence basal sphincter tone, and if you have a very low sphincter tone in your lower esophageal sphincter, you can have reflux of stomach content. And if you increase the sphincter tone, you may prevent the reflux from the stomach going to the esophagus. If you stretch the smooth muscles, you will get an increased action potential frequency. This is kind of stress activation, followed by a decrease back towards the original tension, which is stress relaxation. And this slide in fact shows that you have an activation of, you have a change in your membrane potential, and if this increases above a certain threshold for contraction, then you will get a contractile activity. So the electrical activity in fact drives the contractile force, but you need to become above a certain threshold to really induce a contractile activity. So you have these kind of slow waves, which are repetitive changes in the electric potential and in the threshold, and if they are above threshold, like here, then you will have a contractile activity, which is a contraction that you can measure with certain equipment like manometry. So it's an electrical force that drives the contraction. And you have several types of contractions. You have very rapid contractions, depolarization and a rapid contraction, which are phasic contractions. And if you have, let's say, several phasic contractions, not simultaneously but afterwards within the gut, then you will get transport and peristalsis. And you have tonic contractions, which remain during a longer period and which lead to closure of the sphincter. So this is the phasic contractions lead to activity and to transport in the gut, while the tonic contractions lead to closure of the sphincters and a high basal tone. The innervation of the gut, the gastrointestinal wall, is by large dependent on the enteric nervous system. And if you do a small bowel transplant from one patient to the other, you have a complete denervation of the gut. And despite the fact that the gut is denervated, it is still able to generate peristalsis. So the gut may, is in fact running its own electrical and neural activity. So it's not dependent. It can be influenced by the central nervous system, but in case there are no connections, it can induce peristalsis by itself. Yes? This is the autonomic nervous, that is, let's say, the parasympathetic, and the sympathetic is the autonomic nervous system. and it comes from the central nervous system, and then you have locally in the gut you have a lot of neurons, which is called the enteric nervous system. And the enteric nervous system can generate peristalsis, etc., by itself. It doesn't need the central regulation. In fact, this shows it again. You have here the enteric nervous system and the myenteric plexus. It regulates muscle contractions, but also secretion of endocrine cells, secretion of secretory cells, regulation of the tone of blood vessels and the blood flow. And let's say from the parasympathetic route you have the vagus nerve, but more distally in the colon you have also the pelvic nerves. So the parasympathetic route is, let's say, for 90% the vagus, but for 10% the most distal part is by pelvic nerves. And the sympathetic nervous system is post-ganglionic nerves, and that regulates the whole GI tract. This again shows, let's say, a complex network of neurons in the myenteric plexus in between the muscle layers, but also in the submucosa, where the plexus of Meissner, etc., regulate the secretion of fluid and the secretion of enzymes. So you have the Auerbach plexus, the myenteric plexus, which is in between the muscle layers, and you have the plexus of Meissner, which regulates the secretion and the blood flow and is located in the submucosa. So you have not an intense autonomic innervation of the GI tract by the vagus and by the sympathetic nerve system, but in case there is no connection, the enteric system can regulate it by itself. And again, this was also shown in one of the previous slides, you regulate smooth muscle contractile activity, secretion, release of endocrine cells, a lot of vasoactive and, let's say, endocrine substances and hormones, regulation of the tone and the flow in blood vessels. And you have several reflex pathways. It's not all coming from the brain to the gut, but also going from the gut to the brain. So there are a lot of sensory neurons in the GI tract, and these sensory neurons can sense, let's say, mechanical forces, distension, but also they can sense nutrients, and they have chemoreceptors. So you have a lot of receptors there. They can sense substances, they can sense tension, and then they send signals via the autonomic nervous system to the central nervous system, and that may be at the subconscious level, but also at the conscious level. So you don't become aware if there is a lot of distension, of pain in your abdomen and of pain in your gut. So this is sensory information going to the brain, and then from the brain going back to the guts, and then you may get a reflex contraction or relaxation of the bowel. So you have reflex pathways going to the central nervous system via the central nervous system, but also via the spinal system, which are spinal reflexes. And you also have reflexes that remain within the gut, so they do not need the autonomic nervous system or the central nervous system. And these enteric reflexes are very important for the process of peristalsis. So you may have a stimulus in the gut wall, let's say a mechanical stimulus, but also chemoreceptors and nutrient receptors, and via the enteric nervous system and the network, they may stimulate smooth muscle cells and lead, let's say, to contractile activity or to secretory activity. If you have nutrients here, you will get, by a reflex, also secretion of fluid and secretion of enzymes. So these are short reflexes remaining in the gut, but you also have reflexes going to the spinal system and the central nervous system. If you have a closer look at the muscles and at the enteric nervous cells, then serotonin is an important neurotransmitter. So you have serotonergic receptors at the enteric nerve cells, and within the enteric nerve cells you get release of acetylcholine. It's released in between the space between the neurons and the muscles, and you have at the muscle here muscarinic receptors by which the acetylcholine will activate the muscle cell. You will get contraction. But you also have at the enteric nervous cells, you have other type of receptors like dopamine receptors. And you have also drugs that influence these type of receptors, and by that you can influence, let's say, neurotransmission and also muscular activity. Serotonin, acetylcholine are important neurotransmitters. And this is the principle of a peristaltic reflex. If you have a bolus of food or a bolus of, let's say, digested food products in your stomach or in your large bowel or in your small bowel, when you get a distension of the bowel wall, there is a triggering of certain receptors, especially of mechanoreceptors. And in the more, you get a reflex, and in the more oral part of the gut, there will be a contraction. So there will be a high pressure, and there will be a transport of the bolus to the more aboral way. And in the aboral part, there the muscles will relax, so there will be more space to transport the bolus more distally. And again, this is a picture of the peristaltic reflex. You have stimulation of enteric nerves in the gut wall where there is mechanical distension, and in the oral part you will have contractions of the muscle wall which lead to transport of the bolus, and what will help is that in the oral direction there will be relaxation, and there will be much more room to transport the food bolus. So the peristaltic reflex may occur within the enteric nervous system by itself. It doesn't need, let's say, input from the central nervous system, but usually it is. And especially parasympathetic activation will stimulate the motility, will stimulate the digestive process, while the sympathetic activity will reduce it. It's just more like a stress response. So again, this is the enteric neuronal circuitry, where you have on the oral side you have more stimulatory neurons, while on the aboral side you have inhibitory neurons. And the small intestinal motility can be divided in two separate parts. You have a digestive motility, and digestive motility has to focus on optimal contact between the nutrients and the surface that has to digest and absorb the nutrients. And you have an interdigestive motility. And the digestive motility contains segmental contractions which give an optimal contact between nutrients and the absorption phase. And you have peristalsis, and peristalsis is, let's say, the transport of the food bolus through a larger part of the small bowel. These are segmental contractions, which are more going proximal and going distal, and then when you have segmental contractions, the food bolus will remain almost in the same segment. The interdigestive motility is another part of the motility. That's the motility in the resting phase, when there is no food in the stomach. But still, then there is some motor activity. And you have phase 1, which is a phase of rest and quiescence. Then you have phase 2 of irregular motor activity, and you have phase 3. And phase 3 is a phase with very dense motor activity. It starts in the stomach with contractions with high amplitude and with a frequency of 3 per minute. And these contractions are propagated to the duodenum. There you have contraction frequency of about 10 per minute, 10 to 12 per minute. And this phase 3 is a kind of housekeeper. Debris and certain cells and some food will remain in the stomach and the small bowel, and this housekeeper will work on it that all the remainings, that you get rid of all the remainings in the small bowel. And so the MMC starts in the stomach, it goes up to the end of the small bowel, but will not be propagated into the large bowel. And these MMCs, of migrating motor complexes, are initiated by certain peptides. And motility is a proximal gut hormone that is released in the fasting state and will induce such a phase 3 motor activity. And if you infuse in the fasting state to a healthy volunteer motility, then you will be able to induce a phase 3 in the stomach and in the small bowel. And this is what we record, and when we you can put in a tube in a healthy person or in a patient, and you can try to record motility, and you get this kind of graphs. And we have several recordings in the antrum. We have a recording in the pyloric region and in the duodenum. And here you see these contractions with a frequency of 3 per minute, high amplitude. These are typical ample contractions. And here you have the phase 3 activity in the duodenum, low amplitude contractions with a high frequency, and this phase 3 progresses just more distally. So this is a typical phase 3 of the interdigestive motor complex that progresses more distally into the small bowel. The motility is regulated by the enteric nervous system, but also by the central nervous system and by intestinal hormones. And I mentioned already motilin, but another regulatory gut peptide is cholecystokinin, which results in, upon release, results in contraction of the gallbladder, stimulation of pancreatic enzyme secretion, but also induces intestinal motility. You have conditions where the motility of the gut has changed, and if you have no motility, you will not have transport, and then you get into trouble because you will not be able to digest and absorb nutrients, and you will lose weight, you will get undernourished, etc., etc. So transport, optimal transport, is very relevant for nutrient digestion and absorption. And this is an example of a patient with a disorder which we call pseudo-obstruction. If you have obstruction, you have a mechanical narrowing of the gut, and that will not allow transport of nutrients, transport of a food bolus. But in pseudo-obstruction, there is no real obstruction, but it's the motility that has changed. There is a reduction in motility, and because of that, no transport. And then you get no real contraction upon measuring the motility. You just get these lines, and where in fact the motility is not present. And that will result in bacterial overgrowth, in malabsorption, and also in weight loss. We also have in the gut several sphincters, and we already discussed that the basic principle of a sphincter is that the sphincter is usually closed. It has a high basic tone, and just upon, in the esophagus, you have a sphincter here in the upper esophageal sphincter. If you swallow, then the sphincter will open, and then it will contract again. The same will happen in the lower esophageal esophagus, the lower esophageal sphincter. If you have a sphincter at the end of the stomach, in the pylorus, you have the Oddi sphincter between the bile ducts and the duodenum, and you have the valvula bohini, which is the area between the terminal ileum and the colon, and you have the anal sphincter. And if you look at the structure, at the anatomy, you can see that the structure of the sphincter is somewhat different from the other part of the gut, where the muscle layers are much more enlarged and broader. And the innervation of the sphincter is by excitatory and by inhibitory neurons. And if you have a relaxation of the sphincter, so the pressure goes down, then it's by an increase of the inhibitory frequency and a reduction in the stimulatory neurons. So then you get a relaxation, and upon relaxation you get again a contraction. So it's a balance between stimulation and inhibition. And if you increase the inhibitory influence, then the sphincter will relax. Swallowing is a complex process, and it involves the upper esophageal sphincter, but also contractions of the mouth and of the tongue, etc. You need to close your airways. You need to close your nose area also, and by that you can have transport of the food bolus into the esophagus. In the esophagus you have two types of muscles. You have striated muscles and you have smooth muscles. And the upper third part are striated muscles. So if you have a disorder, if you have a patient with a disorder of the striated muscles, you can have also involvement of the esophagus, of the upper part. And with symptoms such as dysphagia, that the food transport is not optimal. This is an example of esophageal motility. And here you see the body of the esophagus, the lower esophageal sphincter and the upper sphincter. Upon swallowing you get a contraction in the pharyngeal region. This is the upper esophageal sphincter, and you have a relaxation of the sphincter, and here you have contractions in the upper, middle and lower part of the esophagus. And here in the lower esophageal sphincter, this is a baseline pressure of 30 millimeters of mercury. Upon swallowing, the pressure will decrease, so the food bolus will be able to pass here and to be transported, and afterwards you go again to your baseline pressure. So this is the principle of a peristaltic reflex in the peristalsis in the esophagus. Question to you. Here you have a radiograph of a patient with a certain swallowing disorder. And this is the abdomen, this is the diaphragm, and this is the esophagus. And it contains a certain amount of contrast. Any idea what kind of disorder this is? Usually the contrast should pass to the stomach in a couple of seconds, and it remains in the esophagus. Sorry? Yes, there is a problem with the sphincter. What other cause of the what other type of disease might be present in this patient? Let's say if he loses weight, if he has dysphagia, that the food will not pass distally. Yes, but also a malignant disorder. You should think of esophageal carcinoma or something like that. In this case, it's a sphincter that is not able to relax. And we call this disorder achalasia. And in achalasia, let's say there is a reduction in the inhibitory neurons. So you have more influence of the stimulatory neurons, and that's the reason that the sphincter cannot relax. So you have a high pressure zone, and food can only pass this high pressure zone by, let's say, very strong contractions in the esophagus, in the esophageal body. And after a couple of years, then the esophagus will become broader and wider and decompensated, and will not be able to push the food through the narrow sphincter. And then you have problems with retention of food, of vomiting also, and losing a lot of weight. And if you do a manometry, well, it's quite evident that the sphincter upon swallowing, you have a relaxation of the with the upper esophageal sphincter, but no relaxation of the lower esophageal sphincter. So this is a problem of the sphincter. And what happens in the esophageal body, in the blue dotted line are the normal, regular contractions, and the red lines are small contractions in these patients, are not going from proximal to distal, but are happening at the same moment, proximal, mid, and distal. These are the simultaneous contractions with a very low amplitude, so they are not effective in transporting food. So you have an absence of relaxation, and you have, let's say, the absence of strong peristalsis. That will result in not be able to transport food and in weight loss. What we can do for patients is to do a balloon dilatation of this part of the esophageal sphincter, and the pressure will reduce, and that sometimes helps to to eat normally again. This is another type of a motility disorder. Any idea? Usually you see a nice line in the esophagus, but these are contractions happening at several points in the esophagus. And this is what we call diffuse esophageal spasms. Let's say simultaneous contractions occurring at the same time, simultaneously, high amplitude, and by that the most part of the esophagus is contracted, and food will not be able to pass along these contracted segments. So you also have dysphagia. Now I mentioned two conditions that had a hypermotility, but you also have conditions where you have a hypomotility. And scleroderma is a systemic disorder with involvement also of the gut, and with low amplitude motility. So you have a low pressure in the lower esophageal sphincter. And to what kind of symptoms will that lead if you have a very low pressure in the sphincter? Yes, a lot of gastric reflux. Because most of these patients have serious reflux disease. And you can have a look in the esophagus with an endoscope, and then you see this typical pattern of esophagitis. Here you have the reduced motility, and it's not in the striated muscle, it's in the smooth muscle. And this will also lead to dysphagia. And this is an example of an esophagitis. In the left upper part you see the view, an endoscopic view of the esophagus, and these red lines with this ulceration are typical of what we call reflux esophagitis. You have another type of relaxation of the lower esophageal sphincter, which are spontaneous LES relaxations. If we swallow, then we have this is the normal swallowing. You have a peristaltic contractions in the esophageal body, and here you have a relaxation of the sphincter. But look at the left part of the figure. Here you see a relaxation of the lower esophageal sphincter. But what is happening in the esophagus? Not much. There is no peristalsis, there is no swallowing. This is what we call a spontaneous relaxation of the lower esophageal sphincter. And it happens a couple of times per hour, and this will help us to evacuate some air from the stomach to outside. So if we burp, then that's because of these spontaneous LES relaxations. Yes, let's say 6 to 10 times per hour. And sometimes not only some air comes up, but also some liquid like gastric content, which is acidic, and then may hurt the, let's say, the esophageal epithelium, and may cause heartburn and may cause esophagitis. So this is a mechanism by which reflux may occur. And the lower esophageal sphincter is a mechanism that will prevent reflux from the stomach to the esophagus. Because usually the pressure in the abdomen is higher, 10 millimeters of mercury higher than the pressure in the thoracic cavity. And if we do not have a sphincter, and if we lie, we would have, let's say, continuous reflux of fluid going into the esophagus. So the sphincter is important to prevent reflux, and if you have a low pressure in the sphincter, you will have reflux, or when you have much of these transient LES relaxation. So there are some factors that contribute to reflux esophagitis, especially if you have delayed gastric emptying. Then the food will remain for a longer time in the stomach. You will get more activation of acid secretion. You will also, by the food, have a reduction of your LES pressure, and that will allow reflux. So it's the sphincter pressure, it's the gastric emptying, it's the acid secretion, and it's also the esophageal peristalsis. And if we swallow saliva, saliva has a buffering capacity. So if we have acid in the esophagus, and if we swallow, the saliva will neutralize the acidic fluid in the esophagus. And we can measure reflux by putting a tube in the esophagus and continuously measuring the pH. And then after 24 hours you get this type of profile. Usually everybody during 24 hours has some reflux. So let's say for 2 to 3% reflux, that may occur, and that is in the physiological range. If you have such an amount of reflux as this patient, which has reflux over 20-30% of the time, that's really abnormal. And we call it reflux when the pH drops below the level of 4. Let's say the red line is perhaps 20 to 30% of the time below this level. Going from the esophagus to the stomach, in the stomach you have in fact two regions. You have the proximal region, which is the region that will accommodate food. If you ingest a large meal, that meal will be stored in the proximal part of the stomach. And a typical activity of the proximal stomach is receptive relaxation. It will allow the food to remain there by increasing in volume in a very short period of time, which is called accommodation or receptive relaxation. And the distal part of the stomach, the antrum, is more capable of inducing strong contractions and let's say helping to empty the stomach from the food. It's all initiated by electrical activity, and in the region between the fundus and the corpus you have a kind of pacemaker region by which you can induce electrical activity. And this electrical activity is typically with a basal frequency of about 3 per minute, and that may induce also contractions. So here you have the pacemaker zone in the region between the fundus and the body, and you have a much broader muscle layer in the distal part of the stomach, helping to get the food emptied from the stomach. So if you have the fundic relaxation, if you have an impaired fundic relaxation, you will not be able to accommodate large volume meals, so you will get satiated more rapidly, so you can only eat small amounts of food. And so early satiety is a typical symptom that may reflect reduced capacity of the stomach to accommodate food. You can measure that, you can measure the relaxation of the proximal stomach. We have equipment for that. And in patients with early satiety, it's the red line, the accommodation of the proximal stomach is reduced. Then going from the stomach, you have an important sphincter, the pyloric region, and that is able to relax upon certain inhibitory activation. It will open, and this is a coordinated action between stomach contraction, opening of the pyloric region, and then the duodenal contraction. So you have an enteroduodenal coordination. And the process of gastric emptying is by enteral contractions. It's the grinding of the food. You have the enteroduodenal coordination, you have pyloric function, you have the proximal stomach accommodation, you have the intragastric distribution, but you also have intestinal feedback. If we want to optimally digest the food, the amount of calories that is allowed to enter the duodenum is not more than 3 to 4 per minute. So if there is more food coming to the duodenum, you get a kind of intestinal feedback that will reduce the gastric emptying process. This is called intestinal feedback. In case of gastroparesis, you have delayed emptying, and you can measure emptying in a lot of ways. You can measure motility, but that will not tell you a lot about function. Usually we measure emptying, this is the gold standard technique, with isotopes, with certain isotopes. If you ingest a meal, and into the meal there is a radioactive isotope, and a patient is placed before a gamma camera, you can follow the radioactivity over the stomach region. And this is immediately after eating a meal. Here the stomach region is filled with the isotope. This is after 30 minutes, and then a certain amount of the isotope is coming into the duodenum, and this is 15 minutes later where more of the duodenum is filled. So if you count the pixels and the radioactivity over this stomach region in time, you will get a kind of curve. And this curve tells you a lot about the gastric emptying process. If you eat a solid meal, then the emptying of the meal is linear. So after, let's say, a regular lunch, after 2 to 3 hours, the lunch will have disappeared from the stomach. If you drink, drinking usually contains less calories, and fluid is much more rapidly emptied from the stomach by exponential rate. So linear is the fast food, and exponential is the emptying of the fluid. In certain conditions, you have delayed gastric emptying. Patients with diabetes, they can have delayed emptying, and so you can this kind of line, delayed emptying of solid food and also of liquids. Gastroparesis is not infrequent, really it is frequent. If you ask people if they have symptoms of gastroparesis, about 2 to 4% of the population will have symptoms related to gastroparesis. And you especially encounter gastroparesis in patients with diabetes. Usually we try to treat gastroparesis by activating the muscles, so by prokinetics or by opening the pyloric region. And one of the drugs we give is erythromycin, and erythromycin is an antibiotic, but it also resembles for structure the motilin, and it will bind to the motilin receptor in the stomach and the duodenum and will activate the motility there and will lead to a more rapid gastric emptying. So erythromycin is a motilin agonist and is a prokinetic agent in the proximal GI tract, helping to treat delayed gastric emptying. Another organ where motility is involved is the gallbladder. You have the gallbladder and you have the sphincter of Oddi. The sphincter of Oddi is a sphincter in between the bile ducts and the duodenum. It needs to be opened to get the bile released to the duodenum. And if we eat, and if some food, let's say proteins or especially fat, enters the duodenum, even very small amounts will activate endocrine cells in the duodenum, and these endocrine cells will release certain peptides like cholecystokinin. Cholecystokinin is released into the circulation, will connect to the CCK receptors, will bind to CCK receptors in the gallbladder, and upon that you will have contractions of the gallbladder. So bile is then entering the duodenum, but also the sphincter of Oddi needs some relaxation. The CCK is giving contractions of the gallbladder, but relaxation of the sphincter here. So bile is entering the duodenum, is emulgating the food, and is helping for the process of fat digestion. If there is reduced gallbladder motility, or if you have stasis of bile in the gallbladder, you might get crystals, and these crystals might join to form stones. So you, let's say at an elderly age of 70 years, about 30% of the people have gallstones. And gallstones can migrate, can go into the bile ducts, and can give symptoms like biliary colics. And in case of, let's say, if a stone is obstructing here the bile duct, you will get an increased pressure in your gallbladder, and this will give, by the mechanical distension, the typical biliary colics, which is very intense pain that is so heavy that you cannot really sit down, but you have to move because of the pain. Going from the small bowel, the bile ducts, now to the colon. In the colon you have in fact three important functions. If intestinal fluid is entering the colon, when it leaves the colon, it's much more dense. So there is a lot of absorption of water and also of liquids in the colon. So this has an important function to reduce the contents and by resorption. There is also some fermentation. You have non-digested products, especially carbohydrates. They get digested to short-chain fatty acids, which are also very relevant, let's say, for the colonic mucosa and a kind of fuel for the colonic mucosa. And then you have the process of motility by propelling the bowel content more distally. And in the colonic motility you have also several types of motility. You have the haustration, which are contractions that are more, not longitudinal, but more circular, and they allow an optimal contact between the resorptive surface and the bowel content. And the second process is that of peristalsis, by which you have some progression of nutrients, or let's say the bowel content more distally. And the typical pattern is that of the high amplitude peristaltic contractions. These are contractions at high amplitude that occur several times per day and will allow transport of the bowel content over a large area of the large bowel. And this is an example of such high amplitude peristaltic contractions. Contractions with an amplitude up to, let's say, 100 or 200 millimeters of mercury. They start in the ascending colon or transverse colon and then propagate within a couple of minutes more distally up to the rectum. And if you do not have these high amplitude peristaltic contractions, you have a motility problem in your colon, and that will result in what symptom? Constipation. You can measure the segmental transit time. It's very easily to be measured. You ask patients to swallow a capsule with radiopaque markers several days, and then after 10 days you make an X-ray, and as is shown here in this X-ray, many of the markers are to be seen on this X-ray. And in the right part of the colon, in the left part of the colon, but also in the sigmoid and rectal region. So this is in fact a slow transit time, and it's not related to one region but in the whole colonic region. This is what we call slow transit constipation. And the last part is the defecation process. If a bolus is of stool is in the rectum, and this bolus is becoming larger and larger, then you will get mechanical stimulation of the bowel wall, and this will result in a kind of reflex. You have the internal sphincter here and the external sphincter, and if you have triggering of these mechanoreceptors, this will result in inhibition of the internal sphincter that will open, but we can only evacuate the stool if we also have inhibition of this external sphincter. So you need, and this external sphincter is voluntary. And then we can really decide whether or not to open the sphincter. If you have, let's say, just you have a bolus in your rectum, you have a relaxation of the internal sphincter, then you have a kind of compensation by the external sphincter where the pressure will increase, and by doing so you will not be incontinent. This is the defecation reflex. Here we measure electrical activity, and here we measure the pressure. In the internal sphincter and external sphincter, here the electrical activity will reduce. This will also result in a lower pressure, and if you increase the pressure in your rectum, the sphincter is open, then that will result in evacuation of the stool to outside, and that's the defecation reflex. If, for instance, here we strain, we get a relaxation of the sphincter, the anal canal, but if we cough, we get a high pressure in the abdomen, and we need to compensate by an increase in pressure in the external sphincter, otherwise we would become incontinent. This is a special type of constipation, which is called anism. This is a kind of paradoxical response of the muscles, where upon straining you do not get a reduction in electrical activity and in the pressure of the external sphincter, but you get an increase. So this is a kind of paradoxical response, and this will also result in constipation. This is an example of a small child constipated, and this is the rectum and the sigmoid region, which is very much enlarged and which contains a lot of stool. Any idea what kind of diagnosis we make here? This is constipation. Yes, sure, it's constipation, but what is the cause of the constipation? Yes, it's a crossing, but in fact it's a segment that is not innervated. So you can have a kind of segment that is not functional. And that's called Hirschsprung's disease. And in Hirschsprung's disease you have this segment with, that contains no ganglia, just neurons that are not connected. And then you also, there is no inhibitory reflex. If you put a balloon in the rectum and if you distend the balloon, you will get this inhibitory reflex. You get mechanical distension of the bowel wall. This will result in relaxation of the sphincter. This is what usually is happening. But in case of Hirschsprung's disease, you have not a connection between the mechanical neurons and the internal sphincter, so there is no relaxation of the sphincter upon this mechanical stimulation. This is called that the inhibition reflex does not occur. And that is typical for patients with Hirschsprung's disease. So the process of defecation is complex. It has local factors, like stretch of the wall and the defecation reflex, but also you have the gastrocolonic reflex. So if we eat, usually sometime after the meal, we get a signal that we need to defecate. And that's because the stomach is distended, and that will result in a gastrocolonic or gastric rectal reflex. So here we end the motility. We started by the swallowing, and we ended by the defecation, just in a nutshell. Any questions? Yeah.
Also, like pacemakers for thinkers to decrease the contraction?
Yes, you have it's at many locations in your gut you have pacemakers. You have them in the stomach, but you also have them in the colon, and they are called the interstitial cells of Cahal. And there the electrical activity starts, is joined together, and has a certain amount of activity, and may then become above the threshold and result in contractile activity.
Is it possible if like these do not work to place like an artificial pacemaker?
Sorry?
Is
Asking.
it possible to place an artificial pacemaker
Okay.
in case of
Yeah.
kind of
Yeah.
kind of disease?
That's a good question, because if you have these pacemakers that in the physiology stimulate the activity, if the activity is not there anymore, will it help with external pacemakers to initiate activity? Yes. Let's say for gastroparesis, if medication is not helpful, if diet is not helpful, sometimes we put in let's say an external device that will activate the stomach. Up to now, the results are not that good. Let's say in 40 to 50% of the patients we can help them somewhat, but in more than half it is not helpful. We also applicate this in constipation disorders, but also in disorders with incontinence. And there it's very there it's very effective. And we do this by sacral nerve stimulation, by continuous sacral nerve stimulation. So let's say in 60 to 70% of the patients that is very effective in preventing incontinence, and in also activating the constipation. So it works in two directions. Okay, yeah?
Does smoking has an effect on the motility?
Okay. Anybody smoking here? Yeah. If that's what people tell. If you smoke a cigarette in the morning, then you feel an immediate urge to go to the toilet and defecate. So the smoking is very much activating the motility. Sorry?
Is it because of the nicotine?
I think it's because of the nicotine. Yeah. As we have a lot of nicotinic receptors also. Yeah. But that's not a reason to start smoking. Yeah? Okay. Well, if no further questions, good luck with your blog, and